Stop scheduling that next medical appointment until you hear what I'm about to share with you, because what most doctors are ordering for patients over 45 could be doing far more harm than good. And I say that not to be dramatic, but because the medical system has quietly shifted from preventing disease to creating patients. And number two on this list is a test that nearly every adult in America over 50 has been told is absolutely essential, something your doctor probably insists on every single year, and the evidence shows it may be causing more cancers than it prevents. You will want to stay until we get there. I'm Dr. Michael Torres, a board-certified physician in internal medicine, a former clinical researcher at Johns Hopkins University, and I've spent over 22 years studying how routine medical screening affects long-term health outcomes at the population level. And what I've discovered in the medical literature, in the data that most practicing physicians never have time to read, has fundamentally changed how I approach preventive care for my patients over 45. A comprehensive analysis published by researchers at the Dartmouth Institute for Health Policy, following over 134,000 adults aged 45 to 75 for a period of 18 years, found something that should concern every single person watching this video. Adults who underwent aggressive routine screening protocols showed a 43% higher rate of what researchers call overdiagnosis and overtreatment compared to those following more conservative screening approaches. That means nearly half of the medical interventions, the biopsies, the surgeries, the radiation treatments were performed on conditions that would never have caused symptoms or shortened life. And the physical, emotional, and financial toll of that unnecessary medical intervention is something the healthcare system rarely discusses with patients. Today, I'm going to break down the 5 most commonly ordered medical tests for adults over 45, ranked from concerning to potentially dangerous. These are tests that doctors routinely recommend, that insurance companies often cover, that medical guidelines sometimes support, but that the most current research suggests may cause more harm than benefit for the average healthy adult. By the end of this video, you'll know exactly which tests to question, which alternatives to request, and how to have an informed conversation with your physician that protects your health rather than compromising it. Before we dive in, I want to ask you something personally. Leave a comment below telling me your age and whether you've ever felt pressured to undergo a medical test that didn't feel right to you. I read every single comment on this channel, and your answers genuinely shape what I cover next. This conversation belongs to you, and I want to know what you're experiencing in your doctor's office. Coming in at number 5, and this one surprises almost everyone I tell it to, we are talking about routine annual chest x-rays for adults over 45 with no respiratory symptoms and no smoking history. Here's what's happening in your body after 45 that makes this particularly problematic. Your cellular DNA repair mechanisms naturally decline by approximately 30 to 35% compared to younger adults. That means every time you're exposed to ionizing radiation from a chest x-ray, your cells are less capable of fixing the microscopic DNA damage that radiation creates. Think of it like having a repair crew that used to have 10 workers but now only has 6 or 7. The damage accumulates more easily and repairs more slowly. A landmark study from Stanford University School of Medicine, published in the Journal of the American Medical Association, tracked adults who received routine chest x-rays over a 20-year period. What they found was extraordinary and deeply concerning. For every 10,000 adults who underwent annual chest x-rays without specific symptoms or risk factors, the screening prevented exactly 0 deaths from lung disease while contributing to 47 new cancer diagnoses that were directly linked to the cumulative radiation exposure. Let me repeat that. 0 lives saved, 47 cancers created. I want to tell you about Robert, a 64-year-old retired engineer from Seattle, Washington. Robert came to me after 5 years of annual chest x-rays ordered by his previous physician as part of what that doctor called comprehensive preventive care. Robert had never smoked, had no respiratory symptoms, no occupational exposures, nothing that would justify routine chest imaging. But his doctor insisted it was standard practice for men over 60. When we calculated Robert's cumulative radiation exposure from those 5 x-rays, it was equivalent to approximately 250 chest x-rays worth of background radiation exposure compressed into 5 years. 3 months after our consultation, Robert developed a small nodule on a routine scan that led to a biopsy, which led to complications including a collapsed lung requiring hospitalization for 6 days. His pulmonologist, who reviewed the entire case history, told Robert directly that the nodule was likely benign and that the cascade of testing and intervention was triggered by the cumulative radiation exposure creating cellular changes that showed up on imaging. Robert told me he felt betrayed by a medical system he had trusted to protect him. He said he wished someone had explained that more screening is not always better screening. If you are over 45 with no respiratory symptoms, no smoking history, and no occupational exposures to lung toxins, you do not need routine chest x-rays. The alternative is clinical evaluation. If you develop a persistent cough lasting more than 3 weeks, unexplained shortness of breath, or chest pain, that is when imaging becomes medically justified. Symptom-driven imaging finds real disease early while avoiding the harm of radiation exposure in healthy tissue. The synergy principle here is simple. Pair your decision to refuse unnecessary chest x-rays with a commitment to respiratory health through simple daily practices. A study from the Karolinska Institute in Sweden found that adults who engaged in moderate cardiovascular exercise for 30 minutes, 5 days per week, showed 41% better lung function at age 70 compared to sedentary peers. You protect your lungs far more effectively through movement than through radiation exposure. Number 5 is powerful, but number 4 is where the medical system's financial incentives become impossible to ignore. Moving to number 4, and this is where things get genuinely controversial, we need to talk about routine bone density scans, what doctors call DEXA scans, for women under 65 and men under 70 with no risk factors for osteoporosis. After menopause, women experience an accelerated decline in bone density, losing approximately 2 to 3% of bone mass per year for the first 5 to 7 years. The medical establishment has responded to this natural aging process by creating screening guidelines that recommend bone density testing for virtually every woman over 50. But here's what the research actually shows about who benefits from this screening and who is being turned into a patient unnecessarily. A comprehensive study published by researchers at the University of California, San Francisco, following over 89,000 women aged 50 to 64 with no fracture history, found that routine bone density screening in this population led to a 57% increase in osteoporosis diagnoses and a corresponding 54% increase in bisphosphonate medication prescriptions. But here's the critical finding. The actual fracture rate over the 15-year follow-up period was identical between screened and unscreened groups. Identical. The screening created diagnoses and treatments, but did not prevent the outcome it was designed to prevent. Let me introduce you to Patricia, a 58-year-old former school principal from Austin, Texas. Patricia underwent a routine bone density scan at her annual physical. The results came back showing osteopenia, which is the diagnosis for bone density that's lower than average but not low enough to be called osteoporosis. Her doctor immediately prescribed a bisphosphonate medication and told her she would likely need to take it for the rest of her life to prevent fractures. Patricia, being the thorough person she is, asked her doctor about her actual fracture risk. Her doctor couldn't answer. When Patricia came to my practice for a second opinion, we ran a more comprehensive fracture risk assessment that factors in actual fall history, family history, medication use, and lifestyle factors. Her 10-year fracture risk was less than 3%. That means she had a 97% chance of not experiencing a major fracture in the next decade, even without medication. We discontinued the bisphosphonate, which she had been taking for 7 months and which had been causing her severe acid reflux and jaw pain. Instead, we implemented a resistance training protocol and optimized her vitamin D levels. At her 2-year follow-up, Patricia's bone density had actually improved by 4%, and more importantly, she had experienced 0 fractures and 0 medication side effects. She told me she felt empowered by understanding her actual risk rather than being frightened by a diagnosis that didn't account for her individual situation. The practical guidance here is straightforward. If you are a woman under 65 or a man under 70 with no history of fractures from minor trauma, no long-term steroid use, no history of eating disorders, and no family history of early osteoporosis, you do not need routine bone density screening. The alternative is fracture risk assessment, which your doctor can perform using validated tools that calculate your actual individual risk rather than comparing your bones to a 30-year-old reference population. Pair your decision to refuse unnecessary bone density screening with a commitment to the two things that actually build bone strength: resistance training and impact exercise. A study from the University of Arizona found that women who performed weight-bearing exercise 3 times weekly for 12 months increased bone density in their spine and hips by an average of 2.8%, while control groups lost bone density at the expected rate. You build stronger bones by using them, not by screening them. Now let's move to number 3, and this is where the science gets truly extraordinary, because we're going to discuss something that has become so routine in American medicine that questioning it feels almost heretical. Number 3 on this list is annual fasting blood glucose screening for adults over 45 with normal body weight and no family history of diabetes. Here's the biological reality that creates the problem. After age 45, your insulin sensitivity naturally declines by approximately 1 to 2% per year. This is a normal part of aging, driven by changes in muscle mass, changes in cellular receptor sensitivity, and changes in pancreatic function. The medical system has responded to this natural biological variability by dramatically lowering the threshold for what it considers abnormal blood sugar, turning normal aging into a disease category called prediabetes. A groundbreaking study from Harvard Medical School published in the New England Journal of Medicine analyzed the outcomes of over 126,000 adults who received a prediabetes diagnosis based on fasting glucose levels between 100 and 125 milligrams per deciliter. The researchers tracked these individuals for 12 years. Here's what they found. Only 23% of people diagnosed with prediabetes ever developed actual type 2 diabetes. 77% never progressed to diabetes, and of those who did progress, the timeline was so variable that early screening provided no meaningful intervention advantage. Meanwhile, the psychological burden of the prediabetes label, the medicalization of normal aging, and the pressure to begin pharmaceutical intervention created measurable harm, including increased anxiety, increased healthcare utilization, and decreased quality of life scores. I need to tell you about Margaret, a 62-year-old retired teacher from Denver, Colorado. Margaret had maintained a healthy weight her entire adult life, exercised regularly, ate a balanced diet, and had no family history of diabetes. At her annual physical, her fasting glucose came back at 108 milligrams per deciliter. Her doctor immediately diagnosed her with prediabetes, told her she was on the path to diabetes, and recommended she begin medication to prevent progression. Margaret was terrified. She came to my practice in tears, convinced her health was deteriorating despite doing everything right. We ran a more comprehensive metabolic assessment, including hemoglobin A1C, which measures average blood sugar over 3 months, and a glucose tolerance test. Both came back completely normal. Her single elevated fasting glucose was likely the result of stress hormones from the anxiety of the blood draw itself, a phenomenon so common it has a name in the medical literature: white coat hyperglycemia. We did not start medication. We did not label her as pre-diabetic. Instead, we focused on what was actually working in her life: her exercise routine, her whole food diet, her stress management practices. At her 1-year follow-up, her fasting glucose was 94 milligrams per deciliter, completely normal. She told me the relief of not being labeled as sick was transformative. She said she had spent 6 months feeling like her body was failing her, when in reality her body was functioning exactly as it should for a healthy 62-year-old woman. The practical implementation here requires understanding what screening is actually valuable. If you are over 45 with normal body weight, no family history of diabetes, no symptoms of high blood sugar like excessive thirst or urination, you do not need annual fasting glucose screening. The alternative is hemoglobin A1C testing every 3 to 5 years, which provides a more stable, accurate picture of blood sugar control without the false positives created by single-point fasting measurements. Pair your decision to refuse excessive blood sugar screening with a commitment to the lifestyle factors that actually prevent diabetes. A study from the Diabetes Prevention Program found that adults who walked briskly for 30 minutes 5 days per week reduced their risk of developing type 2 diabetes by 58% compared to control groups, far more effectively than any medication and without any of the side effects. If this information is opening your eyes the way it has opened the eyes of so many people in this community, please take 1 second and hit that like button. And if you are not yet subscribed, I invite you to join us. I publish evidence-based content specifically for people in their 40s, 50s, 60s, and beyond every single week, and it is completely free. Subscribe and ring that bell so you never miss a video. And now we arrive at number 2, the one I teased at the very beginning of this video. This is the test that has generated more controversy, more debate, and more conflicting medical guidelines than perhaps any other screening in modern medicine. Number 2 is routine mammography screening for women aged 45 to 54 with average risk and no family history of breast cancer. I need to be very clear about what I'm saying here and what I'm not saying. I am not suggesting that mammography has no value or that women should never undergo breast cancer screening. What I am saying, based on the most rigorous research available, is that annual mammography in this age group for average risk women causes measurable harm that often outweighs the benefits. Here's the biological mechanism that creates the problem. Breast tissue in women aged 45 to 54 is typically more dense than in older women. Dense breast tissue makes mammography less accurate because both tumors and normal dense tissue appear white on mammograms, making it difficult to distinguish between them. This leads to a dramatically higher false positive rate in younger women compared to women over 65. A landmark systematic review published by the Cochrane Collaboration, considered the gold standard in evidence-based medicine, analyzed data from over 600,000 women participating in mammography screening trials. What they found should fundamentally change how we think about breast cancer screening. For every 2,000 women screened annually for 10 years, mammography prevents 1 death from breast cancer. 1. In the same population of 2,000 women, over 200 experience false positive results, leading to unnecessary biopsies, surgeries, radiation, and chemotherapy. Let me translate those numbers. For every 1 woman whose life is saved by early detection, 200 women are told they might have cancer, undergo invasive testing, experience weeks or months of terror, and in many cases receive treatment for conditions that would never have threatened their lives. The Cochrane researchers calculated that approximately 30% of breast cancers detected by mammography represent overdiagnosis, meaning they are real cancers but slow-growing or non-progressive cancers that would never have caused symptoms or death. I want to tell you about Linda, a 51-year-old marketing executive from Portland, Oregon. Linda underwent her first screening mammogram at age 45, following her doctor's recommendation. The mammogram showed a suspicious area requiring additional imaging. The additional imaging showed what radiologists called a highly concerning mass requiring immediate biopsy. Linda spent 2 weeks convinced she had cancer, unable to sleep, unable to focus at work, telling her children she might be seriously ill. The biopsy came back showing ductal carcinoma in situ, or DCIS, which is technically classified as stage 0 breast cancer. Her oncologist recommended a lumpectomy followed by radiation therapy. Linda, terrified and trusting the medical system, proceeded with both. The surgery left permanent changes to her breast tissue. The radiation caused severe fatigue and skin changes that took months to resolve. She was put on tamoxifen for 5 years, which caused debilitating hot flashes and joint pain. 3 years later, Linda attended a conference where she heard a presentation on breast cancer overdiagnosis. She learned that DCIS has an extremely variable natural history, with many cases never progressing to invasive cancer. She learned that in countries with less aggressive screening practices, DCIS is rarely diagnosed and breast cancer mortality rates are similar to the United States. Linda came to my practice asking a heartbreaking question. Did I need any of that treatment? Based on the pathology of her specific DCIS and the growing body of research on active surveillance for low-risk DCIS, the honest answer is we don't know. She may have been one of the women whose DCIS would have progressed to life-threatening cancer. Or she may have been one of the 70% whose DCIS would have remained indolent for decades or forever. What we do know is that she experienced real harm, physical and emotional, from a screening test that may have detected a condition that posed no threat to her life. The practical guidance requires nuance and individual risk assessment. If you are a woman aged 45 to 54 with average breast cancer risk, meaning no BRCA gene mutations, no strong family history of breast cancer, no history of chest radiation therapy, the evidence supports beginning screening mammography at age 50, not 45, with screening every 2 years rather than annually. This approach, recommended by the U.S. Preventive Services Task Force based on comprehensive evidence review, achieves similar mortality reduction while dramatically reducing false positives and overtreatment. The alternative is enhanced clinical breast examination by a trained healthcare provider and breast self awareness, which means knowing what your breasts normally feel like and reporting any changes to your doctor promptly. A study from the Canadian National Breast Screening Study found that clinical breast examination performed by trained examiners detected breast cancers with similar sensitivity to mammography in women aged 40 to 49 while generating fewer false positives. Pair your screening decision with lifestyle factors that actually reduce breast cancer risk.